Hi, my name is Lakshman Swamy, and I'm a critical care physician at Cambridge Health Alliance. I was reflecting recently on why delirium has such an effect on me as a clinician, especially in the ICU. And I encountered a patient recently. I was caring for this elderly woman who, on my first day on service, I walked in and I you could hear her across the whole unit. And this is not infrequent in the ICU or in acute care, where someone is just loudly moaning or screaming almost nonstop, and everyone in the unit hears it. It's grating. I think when you're working in that environment, you really are feeling it. You can't kind of get away from it. And it, I think what was striking to me was as I walked in, I kind of immediately registered it and said, this is what's happening. I need to go see that patient, figure out what's going on. But at the same time, part of me was realizing everyone else was taking it as normal. I immediately understood that this had been going on for a while, and I was able to kind of ignore it to a degree. And I realized when I've had medical students or other family members coming into the unit who aren't used to that, it's shocking to hear someone screaming, calling for help, overtly confused, agitated, angry, whatever, and to see everyone just kind of sitting around. And that dichotomy really struck me and made me think about what does that mean? What does it mean about the way we approach patients, approach patient care, approach the agitated or delirious patient? And what does that mean is about what's happening to us as clinicians in this environment? So I sort of thought about my approach to that patient and how I approach the environment as well. And my goals here are really to find ways to treat this patient, to care for this patient while maintaining their dignity and humanity, and also their own safety as well as the safety of staff, because that's definitely often a concern in these cases. And to not let it interfere with the care of other patients, which is not to be taken for granted either. And I think most importantly, in a way, is to not let that get to you so that you can't deliver the care you need to deliver, but at the same time, to not let it make you feel dead inside and unable to feel anything. So let's start with how to maintain dignity and humanity. What I do when I walk into that room, or I walked into that room that day, I took a deep breath walking in. Already, my pulse was racing. You're feeling this, you're walking into this situation where someone is agitated. Took a deep breath, I walked in, and the first thing I do is every time I walk in that room, and even several times in the room, I introduce myself over and over. Hey, I'm Dr. Swamy. I'm your doctor. I'm here to take care of you. I want to do everything I can to keep you safe. So I try to introduce myself and reiterate safety as a goal for the patient's safety. I like to open by saying, I spoke with your family member, whoever, and I say their name. And I think I don't know how much all of this matters, but I think it goes a long way to say, I see you. I see you as a person who's here and in the context of your life. And even though your loved one may not be here with you, which of course would be ideal, is to see patients with their families. But even though they might not be with you, I'm operating under the information that they've given me and knowing them and knowing you as a person. So I think that's an important piece, is walking in, introducing myself, and as quickly as I can saying, dropping the name of a family member and saying, I know you. I know you outside of this moment. And I should say that I'm doing all this even if they are floridly delirious, screaming at me, whatever, or not responding at all. And I kind of see it the same as I approach the intubated and sedated patient. In both cases, I have someone who's not responding to what I'm saying or doing, not directly. And yet, I think in both cases, I assume that they can hear and some part of them can understand everything I'm saying. I do that as much to treat them as human and maintain their dignity, as it is to remind me that this is a human, this is a person who is underneath this, either this thick fog of sedation and all these tubes and lines, or someone who, this is a real person, even though they are clearly not interacting with me right now. So introduce myself, say I spoke with their family, treat them like they can hear and understand me, even if they don't look like they can. And I tell them everything I'm going to do before I do it. So this is even for the smallest things. And these are the things I try to do. I don't always do all of this, but I try to say, as I walk in the, knock on the door, walk in the room, even if the door's open, I knock on the door. I walk in the room, introduce myself. I've spoken to your family member. I'm going to come closer to the bed now. I come closer to the bed. I'm going to examine you by doing this now. Do you mind if I take a look at your feet? Do you mind if I put the stethoscope on your chest? Whatever the things that I'm doing, I'm going to say each little step over and over again. Try to be calm and try to give them as much kind of advance notice of what I'm going to do. I imagine that being in some kind of state of confusion or fear, especially, and seeing strangers walking in, especially masked and gowned and all of that, and suddenly poking and prodding you is not going to help that situation. So I try to kind of soften that as much as I can. Of course, it's still important, especially in the ICU, that I'm laying hands on that patient and really examining them and doing everything I can, especially because so often what's driving their agitation, their delirium, is some organic cause. And so it's really important to actually do all of that work. But I try to, again, soften the blow and say, this is what I'm going to do. This is how I'm going to do it. And then I try to really say out loud and verbalize, I know you're suffering. I know you're suffering. I know you're scared. We're really trying to take care of you. I'm going to try to make you feel better. And I think at that point, I also, they may not be able to tell me that they're cold or whatever, that they're thirsty or something, but if I'm able to kind of pull up the blankets, if I'm able to, in many cases, someone may not be able to actually eat or drink in this situation because there's too high of a risk of aspirating. But maybe there is a cup with water and a swab in it. And maybe I can take the swab and offer it to them. Any little thing like that that I can do as the doctor, I think, hopefully builds a little bit of credibility for what I'm doing, creates a safer environment, hopefully makes them feel a little bit better, and helps me kind of, build on that therapeutic relationship. I understand that, if you've been in these situations, you're probably hearing me say this and kind of thinking, are you serious? Because when you walk into this room where you can hear this person screaming from across the unit, they're not suddenly saying, oh, you're here. Great. Thank God. I felt so unsafe until you came. No, it's not at all like that. I try to be very practical about this. I mean, I know that what I'm doing isn't necessarily getting the same response as it would in someone who was lucid, but I do it all anyway. And I think, again, there's the double benefit of humanizing the patient, giving them their dignity as much as I can, and also reminding myself that this isn't just someone screaming. This is a person, which is honestly really easy to forget. It's really easy to forget that because the truth is that when you're seeing this on and on, like over and over again, not only many patients, but even in one, you habituate to it, right? Now you come out of that room and this person's still screaming. You feel powerless. There's nothing you can necessarily do in that moment. And you've got to move on, right? I need to go and talk to the nurse. I need to go and see the next patient. I need to chart, whatever it is. So I try to kind of, I try to really reiterate the humanization of it. Now, what else when I'm in the room? Because this is delirium and I'm looking for both organic causes of delirium and anything that might be deliriogenic, when I'm in the room, I'm really looking around. What can I do here? What can I do to encourage the day-night cycle? Can I open the window? What's going on with the TV? Is the TV kind of like screaming something that really doesn't feel like it's helping the situation? Maybe I can turn it down. Maybe music is a good idea. Maybe music is a bad idea. I think you kind of got to talk to the family, and kind of see what's going on in the patient's room. I try to, again, make the patient comfortable, and I'm always looking for things. The nurses are so good about this, but I feel like I just have to do it as well and say, is this patient restrained? And if they are restrained, do they need to be restrained? It does happen sometimes that I think we can help in reducing the total amount of time someone is restrained when they don't need to be. And I look at what the restraints are. And I've learned so much from the ICU nurses about all this. But for example, if someone is restrained, mitts are better than wrist restraints. Mitts are the big mittens that don't let you actually use your fingers much. And that's better because at least you can move your arms around, and it gives you some freedom. The mitts are better than the wrist restraints, which really tie you down and can't move your wrist. And the wrist restraints are better than a vest, right? Which like keeps your whole body down. So the restraints, we never want to use them, but if they need to be used in some way, I think it's important to use the least kind of restraining method possible. And then, you know, it goes to the treatment too. The first thing that most people feel like they want to do when they see someone suffering like this is to make the suffering better. And I think that's a really normal and human, it's a good thing to feel that way, but often we can actually do more harm than good. So I walk out of that room and very often the resident or the nurse or someone is going to say, can we try a PRN? Or we've already tried all these PRNs, or can we add something else? We want a pharmacologic fix to this. And sometimes it works, and I think very often you need some amount of that, right? Especially if people have underlying psychiatric disease, they're on a lot of medications, they've been intubated, now they're extubated, they're not getting their medications. Sure, there's a lot of situations where people need medication, but that doesn't mean that everyone who's agitated needs a lot of medication, a lot of sedation, right? First of all, there's the paramount fear that if we give people too much, they will get reintubated if that's the situation. So I worry about that, or intubated in the first place. But much more than that, I just worry that a lot of a lot of the things we do don't help that much in these cases. I think, we try Haldol, the Haldol doesn't work. Then we try Ativan, the Ativan doesn't work. Then we say, what else can we try? And we're adding this and that. And we're kind of putting them in more and more of this soup, this fog of what, I like to approach it by saying, you know what? There's some things that I think are reasonable to try in these cases, and there's a lot of things that are probably best avoided. And high on the list of things to avoid for me really is benzodiazepines. I think in a very low dose in a patient who has no other renal impairment or anything, in some cases maybe it can help, maybe, but I worry that in so many more cases, so much more of the time, it's just really worsening and prolonging the delirium. It's not having a calming effect as much as it's having an intoxicating effect, maybe. So I feel like I see that a lot and I know the literature supports that benzodiazepines are really not helpful for this. And for other agents and for whatever people are using, I always just ask, because rarely am I the first person to give this person a medication in this case. So I usually just ask, did it work? Did what we gave work? And sometimes it works a little bit, but I think people are pretty good about documenting, hey, we gave 2.5 of Haldol and it had an amazing effect. Okay, great. I love it. We'll follow the QTC, and maybe this is working and it's working well for the patient. But a lot of the time, I think I have to really ask myself, am I treating perceived suffering just because the patient's screaming? Am I treating the actual problem, or am I treating myself or even the family by saying like the appearance of this suffering is causing us suffering, it's causing us stress, and we want to make that just go away. We want to make it better. And trying to really take that head on and address it often leads me to realize that the best thing for this patient is to just try to do as much as I can at the bedside without giving them much more in the way of medication. And that's an easy thing, especially for a doctor to say, who can disappear and go into the next room, the next unit, and walk away. I think it's a lot harder to say that to a nurse who's at the bedside the whole time and just feeling like they are watching someone suffer, making someone suffer. So I think that there's a two-way street here. I think the nurse always knows so much more about what's actually going on moment to moment. And hopefully I can add the bigger picture of, well, that might help in the moment, but maybe it's worse in the long run. So the way I try to bring all that together is to really just put the time in at the bedside. And this, I draw an analogy to proning in the earlier days of the pandemic, when proning wasn't done as much at all the ICUs. And it was kind of a big deal to prone someone, because you really need to pull a lot of people, and people are uncertain about it. There's this new protocol. And and to sort of make it easier, I would just try to say, hey, I will come and help prone. Not that I'm so skilled at it or anything, but I think it builds a lot of credibility to say, I'm going to see what you're going through so I understand it. I know you're telling me that there's these challenges. I believe you, and I want you to believe me that I know what's going on and that we're on the same page, and that we all still think that the right thing to do is to prone the patient or to not sedate the patient, and to really spend the time at the bedside to be able to kind of just endure, right? And that's hard. It's hard to just endure, and I think sometimes it is the right thing to do. A lot of the time, in this case for me, it's either someone who has underlying psychiatric disease, who's been extubated, not getting their home meds, and we're hopefully just kind of riding it out until they're able to take PO, and then we can get them their medications again. Or it's just agitated hospital delirium, ICU delirium, and again, we have to kind of not make it worse. The goal is always to not make it worse and try to reduce it as much as possible. In many cases, having family members come in goes a really long way in making that happen. I think that it's important to recognize that being in this situation is hard, and it really wears on us. And I think separate from all of the work related, the burnout related to too much work or bad work or anything like that, this is a real kind of moral distress where we're faced with this clinical situation. It's not like a systems issue or anything. This is really just a clinical situation that we have to handle. And in many cases, no one else in the hospital can really handle it. And it's not easy to do that. It's not easy to endure someone just screaming in agony and saying that you're hurting them, saying that you're trying to kill them, saying that you're not helping them. And it can be that extreme, or it can be as simple as someone who all they want and they're asking for desperately with tears down their face is to eat or for water. And you're kind of like, I can't do that. You're gonna aspirate. We need to get through this. And I mean, of course, I think there's a role for palliative care in all of this to kind of say, is this really what is in the best interests of and the goals of the patient? But so much of the time it is time limited. So much of the time, delirium, you can get through it if you don't make it worse. So I think that it's hard. It's hard to endure that, and I think recognizing that it's hard is important. There's no easy magic fixes to this kind of the hands-on care that we need to provide to someone who is acutely agitated. But I think it does help me to go in and humanize the patient, even though in a way it's like tearing off the Band-Aid or opening up a scab over and over again. Because when you humanize the patient, you're really there with them and they're suffering. That's uncomfortable. It's really uncomfortable. And it's much easier really to just not, right? To treat it as more robotic, right? To be more aloof and to say, these are the objective things that I'm dealing with here. I can do all the same medicine. I can do all the same non-pharmacological things and all of that without really feeling it. But I think that in the long run, for me at least, not feeling it is going to hurt a lot more and make me someone I don't want to be. But it's really really hard to go in there and feel it and be there with that patient and be there with their family. And then to walk out and say, now I need to close that door and put it behind me so that I can see the next patient, so that I can chart whatever it is. And I mean, I always try to remember that it's way harder for the nurses. It's way harder for the people who are in that room more around the clock, for the nursing assistants who are doing really all the hands-on care. So I think that it is a kind of moral injury, and I think we should understand that and appreciate it. But at the same time, I think that that's the best approach I have. So again, my kind of approach is just to start out by thinking about dignity, about humanizing the patient, about reiterating safety for the patient and for us, for the staff, to go in there and to introduce myself, to say the family member's name, to really bring to them hopefully a sense of safety and comfort as much as I can. And to tell them every little thing I'm going to do before I do it. And then to walk out and ask myself the things that I'm going to suggest that we do, the things that we're going to talk about doing on rounds. Are we doing that? Are we doing that to help this patient, to help them get out of delirium, to help them become more lucid? Or are we doing that to make ourselves feel better? And is it really going to make them feel better just to sedate them? I think, as I kind of like to say, you can't sedate away delirium. You've got to find other ways to deal with it, and that makes it hard. But we are here to do the hard things. So that's my approach to the agitated patient. I hope it's helpful, and I look forward to hearing your feedback. Thanks so much.